Hi, I'm Alyssa AD, and this is my case study on Alzheimer's disease. So our case study is about William W., who is a 78-year-old man coming in for a routine physical exam with his son and daughter-in-law. He was diagnosed with a mild cognitive impairment about 4 years ago due to increasing confusion and memory impairment. That then progressed into Alzheimer's disease, which he was diagnosed with a year ago and started on Aricept. The son reports that William seems to be getting increasingly confused and is getting worse. So Alzheimer's disease is the most common form of dementia. It's a neurodegenerative disorder that's characterized by cognitive and behavioral impairment that significantly interferes with a person's social and occupational functioning. There is no cure for this disease, so our goal is to slow the progression of the disease as much as possible. In AD, these plaques develop, and these plaques are a result of the increase in production or accumulation of beta amyloid proteins in the brain. So these plaques develop in the hippocampus, which is a structure deep in your brain that encodes memories, and it develops in other areas of the cerebral cortex that are involved in a person's decision making, thinking, and judgment. And these plaques will tangle and twist within the brain and damage brain cells and neurons. And as more and more brain cells die, it will lead to significant atrophy or brain shrinkage. And it's unknown whether these plaques themselves are what cause AD or whether they are a byproduct of the AD process. So AD is characterized by impairments in memory and disturbances in reasoning, planning, language, and perception. Early on in AD, you'll start noticing the person may repeat statements and questions over and over, not realizing they've asked a question before. They may forget conversations, appointments, or events, routinely misplace possessions, and get lost in familiar places. And those are what you normally see in the early stages of AD. And over time, they'll start having more difficulty in reasoning and thinking, especially when it comes to abstract concepts like money or finances or using numbers. Their judgments and decision-making skills may become impaired. And then they will slowly lose the ability to plan and perform familiar tasks. So once routine activities require sequential steps, such as planning and cooking a meal or playing a favorite game, become a struggle as this disease progresses. And eventually, as they get into the advanced stages, they'll forget how to perform those basic tasks, such as dressing and bathing. And AD also leads to personality and behavior changes. It's very common to see things like depression, social withdrawal, mood swings, irritability and aggressiveness, and a loss of inhibitions with this disease. So we separate this disease into 3 stages. There's a mild, moderate, and severe stage, and we will discuss each one of those. So stage 1 is the mild form of AD. It's characterized by some memory loss, particularly memory of more recent events. Their long-term memory stays intact. So a person in the early stages of AD will likely carry out daily activities of living. They usually are able to function independently, but over time they'll start forgetting familiar words and names when speaking, and their judgment and attention span may start to become impaired. Toward the end of the first stage, a person may get lost due to disorientation, so especially in places that they may not be familiar with, it may be easy for them to get disoriented and lose a sense of direction and get lost. They'll also have trouble finding the right words, may become more difficult for them, so they may actually tend to avoid social situations. You'll start seeing some social withdrawal because having conversations becomes more difficult for them, and this is where depression may come into play here. So a lot of times people in this stage will find ways to compensate for the memory loss. They'll often write themselves notes or make a little reminder list, and they're usually able to function okay. You may start seeing inappropriate and broad mood swings. They may begin to dress inappropriately, like putting on a winter coat in the middle of the summer. They may have impaired logic and sequencing when they're trying to tell a story. They may use words incorrectly. And over time, the conversation may become difficult and disjointed. So stage 2 is a moderate stage. So in stage 2, you're going to see an increase in the severity of the symptoms discussed in the first stage, and they're going to have social functioning is going to continue to deteriorate because of increasing problems with memory, logic, speech, and initiative. So in this stage, short-term memory worsens, so their memory impairment becomes much more pronounced, as well as their mood swings and personality changes. They become more disoriented to person, place, and time. And safety becomes an important issue as they move into the moderate stage. They tend to become more restless, and as we said, they have impaired memory and confusion, and they'll tend to wander. So it becomes a concern that the patient may wander off and get lost. Driving at this stage is usually out of the question for the patient's own safety as well as others. You'll also start to see an inability to perform skilled movements. They'll have impaired muscle control and weakness. It leads to a concern for falls with these patients as well. And this is a stage where a patient may begin to forget the names of or even fail to recognize families and friends. So this can be a very difficult stage for family, especially if they are caregivers for the patient. Inappropriate judgment will become a bigger problem. Hygiene may be neglected, likely because of forgetfulness. Sleep disturbances will start to come into play here. And you also start to see something called sundowning, and sundowning refers to disorientation, confusion, and behavior changes that happen at the end of the day or tend to happen at the end of the day. Often during sundowning, patients may wander, they'll be increasingly agitated or confused. They may even present with psychotic behavior, paranoia, hallucinations, and delusions if they become very agitated in sundown. So stage 3 is a severe stage of AD, and this is characterized by almost total memory loss. The brain actually begins to lose the ability to even control basic biological functions like swallowing. They are completely dependent on someone else to do all activities of daily living. Their physical abilities further diminish, so they will start to lose the ability to walk on their own, to sit up on their own. They'll usually be completely incontinent. They can become unresponsive to stimuli. And usually they will lose their ability to communicate almost completely. They may be unable to speak or even understand what someone else is saying. So now let's go back to our case study of William and talk about a history of his present illness. So at the time of his diagnosis, William would frequently forget things around the house and get more confused about the date and time. He often missed appointments and forgot plans. The son reports that the symptoms seem to be worsening, and he's been getting more confused over the last 4 months. He often forgets to eat and shower and needs reminders from his family. The son reports that William seems to be forgetting more words and has difficulty communicating at times, and that his father seems more withdrawn and isolative. William gets upset and frustrated more easily. The son and daughter-in-law reports that he's more irritable in the evening and at night, and the son is concerned that the Aricept may be ineffective. So things to consider when we talk about the history of present illness with William. We want to look at whether this has been a slow, chronic, progressive change in cognition, or whether this was an acute change in mental status. If it's an acute change, this probably would be a different underlying condition that needs to be addressed. Slow chronic change, it's more likely that he's progressing from the mild stage of AD into the moderate stage. So we definitely want to look at, is this an acute or chronic change? Another thing to consider is there a recent change in environment. People with dementia need a very structured, familiar environment. If they're taken out of that environment, they can have increased confusion and agitation. So some things to consider. A possible infection, particularly a UTI, which can cause delirium in the elderly, can lead to the increased confusion that the son's reporting. We also need to consider possibly dehydration, a low blood sugar, or anemia for the confusion, because we do know that William hasn't been eating well, he's not been drinking well, so is it possible that the dehydration or low blood sugar is causing the change in mental status? It's very common for the elderly to have deficiencies in folic acid, B12, or iron, and with him not eating well, that's something that we should check to make sure he's getting enough oxygen to the brain. Another thing to consider is people with AD develop muscle weakness and have impaired muscle control, so his ability to walk may be impaired and he could have had a fall, so we are concerned that maybe he fell and hit his head and that's causing the change in mental status. If it's an acute change in mental status and sudden confusion, there's always the possibility of a stroke as well, or we also should consider any endocrine or cardiac issues in play. If the patient has a history of substance abuse, there's Wernicke's or Korsakoff's, which can cause cognitive decline as well as confusion. Depression can worsen a patient's confusion. And also the use of antipsychotics has been shown to can actually have the opposite effect and increase agitation and confusion in patients with dementia. Another thing to consider is the patient sundowning. That's usually a good indication that he's going into the moderate stage of AD. So is he wandering or increasingly agitated later in the day or at night? You also want to consider frontal release signs, which are basically reflexes that a person lost when they were a newborn. People with severe AD redevelop things like the grasp reflex. So that's another thing we can check to see if he's developing those reflexes. Patient history. So his medical history has had hypertension, he has arthritis, and he has AD. His social history has 2 children, a son and daughter. The daughter currently lives out of state. He recently moved in with his son and daughter-in-law and his 2 grandchildren approximately 3 months ago. He does not use drugs or alcohol. He's a retired English professor. His wife passed away 6 years ago. The son is the patient's power of attorney. His mother had Alzheimer's disease and passed away at 75, and the father died of lung cancer at 83. No known drug allergies. He's currently on Aricept 10 milligrams daily for the AD, lisinopril 10 milligrams daily for the hypertension, and ibuprofen 400 milligrams every 4 to 6 hours as needed for pain. So looking at the review of systems for this patient, there are reports of mood changes. He's withdrawn, isolative. He's easily upset and agitated, more common in the evenings or at night. He denies any ear, nose, or throat issues, denies any cardiovascular issues. The son does report he has BPs of 130s over 80s, denies any respiratory issues, denies any urinary issues other than 2 episodes of incontinence of urine. Both happened late at night, and the son believes the patient got lost in the home and had difficulty finding the restroom. Denies any GI issues. Denies any musculoskeletal issues. The patient does report he has little interest in doing things. He does feel sad. He's withdrawn. There's episodes of increased agitation at night. He's sleeping more in the daytime, and he tends to stay in bed during the day. And as far as neuro, there is increased confusion and forgetfulness, disorientation to place and time, as well as forgetting words. For the patient's physical exam, his vital signs were 134 over 86, heart rate was 85, his O2 stat was 96% with a temp of 98.8 and a respiratory rate of 18. His weight, he had approximately a 10-pound weight loss since his last visit about a year ago. His mini mental status exam, his score went down from 24 to 20. This is a normal in a person with AD. On average, they decline about 2 to 4 points each year on the mini mental status exam. His Montreal Cognitive Assessment score also went down from 21 to 19. Both these scores indicate moderate dementia in the patient. The Montreal Cognitive Assessment has been shown to be more sensitive to subtle cognitive declines, so it's a very common use for patients with AD. For the patient's physical exam, he has negative frontal release signs. He's alert and oriented to person and place, but not time. He was pleasant and cooperative. He maintains poor eye contact, presents with a sad affect. He's answering questions, but often has to pause and search for the words. His clothes and hair appeared disheveled. All his cranial nerves are intact. He has normal gait and a strength of 4 out of 5. His skin is dry and flaky. Otherwise, he has a normal physical assessment and is relatively healthy. So the labs he had done prior to the appointment was a thyroid panel, CBC, vitamin B12, folic acid, CMP, iron, lipid panel, vitamin D, and a UA. Both his BUN and urine-specific gravity were slightly elevated. Otherwise, the labs were relatively normal. He also had some depression screenings done. Both indicate signs of mild to moderate depression. We use the geriatric depression scale as well as a PHQ-9. Based on this physical exam, we can probably rule out things like an infection, substance abuse, as well as anemias. Based on the patient's history of present illness, his review of systems, and the physical exam, we can probably rule out things like substance use, recent fall was not reported. We can probably rule out the likelihood of an infection, any anemias, the possibility of stroke. This has been a slow chronic change, and most likely based on our assessments, it's a cognitive decline due to the progression of Alzheimer's disease from the mild to moderate stage. The patient may have some mild dehydration because he's not drinking as well as he should be because he's forgetting to drink and eat, and some signs of mild to moderate depression within the patient. So treatment options for patients with Alzheimer's disease, there's no cure. Our goal of treatment is to slow the progression of the disease. So there are 3 drug classes that do that: cholinesterase inhibitors, NMDA receptor antagonists, as well as a combination of both of those drug classes, the cholinesterase inhibitor and the NMDA receptor antagonist. We also use SSRIs and mood stabilizers for the secondary symptoms of AD, so those mood swings, the irritability that you may see, the psychosis. Certain SSRIs have been shown to be effective in improving mood, decreasing irritability and agitation, and improving sleep. They are particularly important with patients with AD because over 30% of people with AD will develop some sort of depression. Mood stabilizers such as Depakote can be helpful in the treatment of disruptive behaviors and outbursts of anger. Trazodone has been shown to be helpful in treating sleep disturbances in patients. Antipsychotics should be used with caution in these patients. The patients do enter psychosis sometimes and get very agitated, and the normal drug of choice would be an antipsychotic. However, antipsychotics are black boxed for elderly patients with dementia because they have been shown to have an increased risk of stroke and death in older adults with dementia. They also have been shown to increase agitation or psychosis in certain patients with Alzheimer's disease, so they should be used with extreme caution. So the first drug class is cholinesterase inhibitors. This includes Aricept, Exelon, and Razodine. All these drugs are used to treat the early to moderate stages of Alzheimer's disease, with the exception of Aricept, which is approved for all stages. So these drugs work by reducing the breakdown of acetylcholine in the brain. So in patients with AD, acetylcholine, which is a neurotransmitter that's essential to help neurons communicate and it's essential for processing memory and learning, is decreased in both concentration and function. So these work by inhibiting the enzyme that breaks down acetylcholine and thus increasing both the level and duration of acetylcholine. All these drugs have been shown to have a modest benefit on the measures of cognitive function and activities of daily living. They have been shown to have slower declines on cognitive and functional measures in patients. They have also been shown to alleviate non-cognitive manifestations of AD, such as agitation, wandering, and socially inappropriate behavior. However, they do not address the underlying cause of the degeneration of the neurons in the brain, which continues during the disease. So the disease process is still continuing. This just reduces or slows the cognitive decline in the patient. So all these drugs tend to share a common profile in terms of adverse effects. The most frequent adverse effects we see are nausea, vomiting, diarrhea, and dizziness. These drugs tend to be well tolerated by patients. You usually titrate up. Another concern is these do provoke symptomatic bradycardia and syncope and can precipitate fall-related injuries. So especially with patients who may have a pacemaker or some sort of cardiac history or taking any cardiac meds that may cause bradycardia, you do need to watch for the heart rate in patients taking these medications. There are certain studies that do indicate that there's a cognitive and behavioral decline associated with patients who have an abrupt termination of cholinesterase inhibitors as well. They have been shown to have some withdrawal effects that can cause delirium in patients. So the next drug class is NMDA receptor antagonists. This only has one drug in it, and that is Namenda. So this focuses on blocking sustained activation of the NMDA receptors. So in patients with Alzheimer's disease, their cells may make too much of a neurotransmitter known as glutamate. So when this neurotransmitter is passed from one neuron to the other, it attaches itself to a new cell by using what's known as an NMDA receptor. And this allows the glutamate to dock to the new cell. And once it's docked to that receptor, it passes calcium into the cell, which carries the electrical or chemical signal as a last step. And this is an important neurotransmitter in terms of learning and memory and processing. So in people with Alzheimer's disease, when they make too much of this neurotransmitter, the nerve cells get too much calcium, and that can speed up damage to the nerve cells. So the goal of a drug like Namenda is to make it harder for that glutamate to dock onto the receptors, and it allows important signals to flow between the cells and slows the destruction of the brain cells. And Namenda has been shown to prevent further nerve damage and to slow cognitive decline in moderate to severe AD. Several studies show that Namenda can be safely used in combination with cholinesterase inhibitors. It's often used in combination with Aricept. The combination of Namenda and cholinesterase inhibitors have been shown to significantly delay institutionalization in patients with AD, and it suggests that the combination does affect cognition in patients with moderate to severe AD, but not in early stages of the disease. And then there's a combination cholinesterase inhibitor and NMDA receptor antagonist, and that's Namzaric, and that's basically Namenda and Aricept combined. It was approved in 2014, so it's a relatively new drug, and it is very expensive. Common side effects when we're talking about Namenda, as well as a combination drug, is dizziness, headache, confusion. So treatment options for this patient. So we have a few options in terms of the progression of the AD into the moderate stage. We can either stop the Aricept and start the patient on Namenda. We can stop the Aricept and start another cholinesterase inhibitor. We can continue Aricept and start Namenda and use it in combination, or we can stop the Aricept and start Namazaric, which is that combination drug. And then options for dehydration. Since the patient seems to be only mildly dehydrated, that would be education on the part of the caregiver, setting out glasses for the patient, giving them reminders, encouraging fluids. And then for depression or mood changes, we can consider further depression screenings, possible referrals to psychiatry or a specialist. We could start the patient on an SSRI or start them possibly on a mood stabilizer. So my plan of care for William would be to start him on the generic form of Namenda, 5 milligrams daily, and then to continue on the generic form of Aricept, 10 milligrams daily. This combined therapy is often going to be the therapy of choice for moderate to severe Alzheimer's disease, and it only costs about $30 to $40 for both drugs. There is some mixed evidence on whether this combined therapy is more effective than monotherapy. However, some research suggests that when combined, Aricept and Namenda can reduce agitation and other behavioral symptoms. Namenda can be safely used in combination with cholinesterase inhibitors, and then the combination of Namenda and Aricept have been shown to significantly delay institutionalization in Alzheimer's disease patients. And both drugs separately have been shown to have beneficial effects in the moderate to severe stages of AD, which is why would I lean towards a combination treatment for this patient. Another thing is discontinuing any cholinesterase inhibitor or any abrupt termination has been shown to lead to faster cognitive and behavioral decline in patients, and has been shown to have some withdrawal symptoms such as delirium. Patients who continued on Aricept all the way through the moderate to severe stages tended in studies to have better outcomes or have slower cognitive decline than patients who were stopped. I would not switch this patient to another cholinesterase inhibitor because no cholinesterase inhibitor has been shown to be more effective than the other. And Exelon and Razidine have not been approved for severe stages of AD. Aricept has been approved for all stages, so I can continue treating the patient with Aricept through the moderate into the severe stage. I would not use the combination drug Nemarzik just because it was approved in 2014. It's new and it's very expensive. It's about $400 to $430 just for a 30-day supply compared to the $30, $40 if the patient just bought both medications separately. So some things to consider in patients who are on Aricept. Aricept is contraindicated in patients with a heart block or bradycardia and patients with a history of GI bleed or peptic ulcer disease with GI bleeds. In rare circumstances, Aricept has caused GI bleeds, so we do recommend that patients avoid NSAIDs just due to that effect. The most common adverse effects, once again, would be that nausea, vomiting, diarrhea, insomnia, headache. There's sometimes a loss of appetite or increased frequency in bowel movements. Less common side effects are the GI bleed, the syncope, dizziness, bradycardia, heart block, or Stevens-Johnson syndrome. Another thing to know when we talk about Aricept is to avoid anticholinergics and use with caution and medications that slow heart rate. So anticholinergic medications work by decreasing the activity of acetylcholine. Therefore, it opposes the effects of Aricept. So it will make one or both medications ineffective. So it should be avoided in people with people who are taking any Aricept. We also should watch for any medications that may slow the heart rate, such as beta blockers like atenolol, amiodarone, calcium channel blockers such as rapamycin, digoxin, can all slow the heart rate. So you do want to watch for symptomatic bradycardia if the patient is taking any cardiac meds. And things to look for patients who are taking Namenda. Used in caution with patients with cardiovascular disease, seizure disorders, and or hepatic or renal impairment. Some common adverse effects would be dizziness, confusion, headache, hypertension, constipation. And less common adverse effects would be acute renal failure, DVTs, thromboembolus, hepatitis or liver failure, and Stevens-Johnson syndrome. So there's no dosage adjustment is needed for patients who are mild to moderate renal impairment. Severe renal failure you should use with caution with Namenda, as well as severe hepatic failure. Namenda should be used with caution. Another thing to consider is the clearance of Namenda is reduced by about 80% if the urine becomes alkaline. So any pH of 8 or greater. Therefore, any alterations in the urine pH towards alkaline conditions may lead to an accumulation of the drug with a possible increase in adverse effects. So urine pH can be altered by diet, drugs, or the clinical state of the patient. So any patient who has severe infections of the urinary tract, any acute renal issues or renal acidosis could be at risk for having a more basic urine. So you should be used in caution if the patient does have any of those conditions. So things to monitor when the patient is on Aricept or Namenda, we want to look at their renal function. So we want a baseline creatinine. Liver function, you want a baseline liver function test. You want to watch the patient's blood pressure because there is a risk for hypertension with NMDA. You want to obviously recheck the patient's cognitive status so you can monitor for cognitive decline. We want to look at heart rate and rhythm. We want to teach the patient and educate the caregiver on signs and symptoms of a GI bleed. We want to educate them that they should avoid NSAIDs. So for my final care plan, once again, I would start the generic form of NMDA, 5 milligrams daily, and continue the generic form of Aricept, 10 milligrams daily. The patient can continue on his lisinopril. There's no known drug interactions. His blood pressures look good. We would instruct him to avoid NSAIDs and to stop the ibuprofen just to avoid that risk of the GI bleed. He can use acetaminophen or Tylenol for his joint pain. We'll continue to monitor blood pressure because there was a risk for hypertension with Aricept. We could also consider giving him citalopram, 10 milligrams daily, for depression and mood changes. Citalopram has been shown to be beneficial in mood and other neuropsychiatric symptoms in patients in the moderate stage of AD. It has been shown to reduce daily agitation among patients, and it's shown to reduce caregiver stress. The only concern with citalopram would be it does increase the QT interval. So in cardiac patients, you would have to watch for that. This patient has no cardiac history, so we could watch heart rhythm and rates if that's a concern. We'd also like to discuss caregiver options, possible residential treatment, and the goals for treatment. So what is the son and the daughter-in-law's plan long term? Are they going to be able to care for him? He probably will need a full-time caregiver as AD progresses, especially into the moderate to severe stage. He'll be very dependent on someone to take care of him. And we're also worried about caregiver role strain as well, so support groups for them. And what are their expectations for this treatment? We could also consider a referral to a memory clinic or specialty center for management of the disease and behavior changes if the patient worsens. We should educate the caregivers on signs and symptoms of dehydration and GI bleed so they can pick up if something's wrong or there's a concern, and we should have a 3-month follow-up with the patient to see how the interventions are working.